before we leave upfront therapy, probably the most important thing that the audience needs to know relates to maintenance therapy, because we have randomized trials with overall survival benefits in a couple different situations. So in just a few minutes, Alexey, the key messages for the audience about maintenance that they need to know about, whether or not, if they have that older patient who gets something like BR or something along those lines, less aggressive, the older patient, and then the younger patient who gets a transplant. What do people need to know about maintenance in those scenarios?
So mantle cell lymphoma is a subtype of non-Hodgkin lymphoma where maintenance has been, as John, you mentioned, associated, maintenance CD20 antibody therapy has been associated with improvement in overall survival in 2 different settings. So one setting is following induction chemotherapy, and that specifically refers to R-CHOP. So this data was updated at the current meeting, abstract by Schuster. And that abstract referred to the elderly MCL study from Europe, which enrolled patients over 60 years old with NRS stage 2 to 4, and randomized them to R-CHOP or FCR, followed by rituximab maintenance or not. And so fludarabine cyclophosphamide at this point, we don't use it for mantle cell lymphoma as an induction, partly because of the study, it didn't perform as well. But so following R-CHOP, the key message there is that there was a benefit in 5-year overall survival, which went from 60% on the interferon arm to 80% on the rituximab arm. So a very clear advantage, very clear benefit. So the second setting where data is clear is following autologous stem cell transplantation. And that has been published in New England Journal of Medicine. And just recently, there is also a clear progression-free and overall survival benefit in that study. So John, you asked me about bendamustine rituximab. And as far as I know, there is right now not a clear, unequivocal data that maintenance rituximab is absolutely indicated there. So the Still Maintain trial actually was a negative trial presented in 2017, where there was not a benefit to progression-free survival following rituximab maintenance with BR. So I think the jury is still somewhat out there. What do you think?
Yeah, I would say that that study I found to be relatively underpowered, and I think why would maintenance work in R-CHOP and maintenance work in transplant and not after bendamustine? I'm sure one can back into an argument, but I tend to use maintenance after BR and mantle cell.
And of course, in other histologies, there is data for
Sure.
PFS following BR.
Good.
How about the length of maintenance that you deliver? How long?
Both of this, well, the transplant study, I believe, was 3 years
Right.
after transplant, and I think the Schuster study was indefinite until progression.
Indefinitely,
There
yeah.
were many
So I
people,
think-
more than 5
yeah.
years, still
Yeah.
getting maintenance rituximab.
Yeah.
So that's an important question, I think, when we look at the pharmacoeconomic context where we have to think on how we do this maintenance for 2 reasons. Because we're going to go beyond rituximab. There's trials looking at combining biological agent with rituximab to improve the maintenance, and maybe that's a great form of setup for immunotherapy. But at the same time, for example, the R-square versus rituximab maintenance in Europe in elderly patients, but also treating patients until progression up to 7 years in the context that we have potentially more toxicity, but also cost. So should this maintenance, I would argue, be more based on MRD and a little bit on the, sort of the Nordic model that you can convert patients very easily, preemptively into negative PCR, and I don't think that they will have a worse survival.
Yes.
It's very
That's
difficult to show.
and the Nordic approach, or the Nordic study showed that, and I think it's a smart way to use maintenance therapy rather than just everybody gets it forever.
Correct. I think we're overdoing maintenance. I really do.
Yeah,
As
and
much as
that
I'm
may,
convinced.
you were asking about
Yeah.
MRD,
Yeah.
John. You know, that may be a way in clinical practice that you might want to use MRD.
Right.